So let's switch gears for a second. So this is now a Crohn's case, a role of mucosal healing, and I'd be curious to hear if you're using capsule endoscopy in your practices and how you're using it in somebody with moderate to severe Crohn's, actually with minimal symptoms. So how would you leverage the new medicines for Crohn's disease in terms of mucosal healing, and what's the role of a capsule? So this is a 59-year-old male, history of hypertension and first-degree AV block with Crohn's disease. 3 years ago, he was diagnosed with Crohn's. He had guaiac-positive stool and about a 10-pound weight loss and was found to be anemic. Otherwise, he had some non-specific bloating, and interestingly, as many of our patients, he's not terribly sick. He's not bothered by GI symptoms. His primary care, I think, was worried about cancer, to be quite honest, and got a CAT scan. And the CAT scan showed that there were inflammatory changes in the jejunum and TI. A colonoscopy was performed. He actually had never had a colonoscopy, even a screening colonoscopy. And this is what you see. So normal colon, but you pop into the TI, and you see these ulcerations consistent with Crohn's disease. So, and I'll say for purposes of this case, the biopsies come back. He does have granuloma. This looks like Crohn's. There are no red herrings. This isn't an infection. This is Crohn's disease. So Gil, this is a guy who initially had a CAT scan that showed jejunal inflammatory changes, TI changes. You do a colonoscopy and you say, you know what, this looks like newly diagnosed Crohn's. He's 59. Maybe he's had this for a while. Would you do a pill endoscopy to further evaluate the small bowel?
That's a good question. I'm not sure. I think that I'm going to think out loud and come to an answer for you. But you know,
that's why we put you on the spot.
So and it goes to what you showed us on colonoscopy. I think if it's a slam dunk colonoscopy that this is Crohn's disease and that it fits with his anemia and his weight loss, and you know, because that sounds like something's really going on here. If this were maybe a little bit milder, I would do a capsule. And really try to get a sense of the full extent of things, irrespective of the CT scan. The CT scan, though, tells me that there's already something there that's, you know, significant burden of disease, and we assume that it's related to the Crohn's disease here. So I'm not sure with seeing this and the CT scan, I'm not sure there's utility for a capsule at this point for diagnosis.
So Marla, would you get a capsule? And if your answer is, as I think Gil's is no, if you say no, when do you get a capsule endoscopy? Yeah. Gil's mentioning if he had milder symptom or milder disease, but these symptoms, maybe you'd get a capsule. What would you do, and would you get a capsule in this case?
So not that I'm not disagreeing with, you know,
well, it's okay if you do.
How Gil came to that decision, but one thing I do want to know is, if you're going to monitor him, forget about, you're not using it as a diagnostic, but you're not going to repeat scanning. People hate MREs, and you may have objective evidence that you can document where the location is, and you want to show change. Do you think that perhaps in this case, a wireless capsule would be a much more patient-friendly way of monitoring healing?
Yes.
Okay.
We actually had
Marla wins again.
No, but she asked me the question in a different way. I mean, for monitoring purposes, yes. For diagnosis, I don't think you need a capsule for diagnosis here. We actually had an abstract presented today. We did capsule endoscopy at baseline and 6 months, and colonoscopy at baseline and 6 months, and showed extremely high correlation between capsules and colonoscopy as monitoring. And actually, in that case, capsule picked up many things that colonoscopy didn't. So I think that there's data out there, prospective data. It's from a monitoring standpoint, I would completely agree with Marla. From a diagnostic standpoint, I don't think it's necessary though.
All right, so he did get a capsule endoscopy, and this was seen about an hour and 18 minutes in. And you can see, I don't know if the pictures are going to show as well in your slides, but he does have these areas of ulceration. This is, again, probably in the mid-small bowel. This is in an area where he had the changes on a CAT scan. And I guess an obvious question to ask, not that I think this is going to happen with this guy, what's your biggest concern if you didn't do pre-capsule? What's your biggest concern with the capsule that gets retained? So this one did not get retained, but he had disease. All right, so he has what looks to be jejunal Crohn's and TI Crohn's, anemia, he's lost 10 pounds. What do you do? So you have all these choices: 5-ASA, steroids, thiopurine, methotrexate, anti-TNF, vedolizumab. Unlike the first case, we have ustekinumab. And would you give this? Same question as the other one. 59-year-old male, would you give monotherapy biologic or would you give a combination? So Marla, you first, and then Gil, how would you approach this patient?
So newly diagnosed, not exposed to TNF historically, 59, turning 60. I'm making him older than he is. I'm trying to make a point that I need to start thinking about what's the optimal therapy for this patient. And to be very frank with you, he's not as symptomatic to need prednisone. This is at the moment the way you described it. And obviously 5-ASAs is a non-starter. I don't even think it should be listed. It's, particularly in this case. And to be honest with you, I would actually use ustekinumab in this patient.
Okay. And ustekinumab is monotherapy.
Monotherapy, ustekinumab, in a newly diagnosed Crohn's patient, never seen TNF, heading towards 60, low immunogenicity, effective first line. That would be where I'd go.
And just to reiterate the question you answered before, does ustekinumab have a black box warning?
Does not have a black box warning and has been out since safety-wise for a decade.
Okay, Gil, would you do anything differently?
Actually, no. I would agree with Marla here. And I want to emphasize the point that Marla made about 5-ASAs because we see so many referrals of isolated small bowel Crohn's disease in patients on 5-ASAs. And I agree with Marla. It shouldn't be on the list. The patient has deep ulcers and inflammatory disease, significant inflammatory burden. 5-ASAs really should not even be part of the conversation. They're not approved for this indication and really don't have any healing effects in the small bowel. So I just want to emphasize that point. I think that anti-TNFs could be an option.
Yeah.
But we have now ustekinumab available, and from a safety standpoint and efficacy standpoint, not needing to use going with monotherapy, I would agree with Marla. I would certainly offer ustekinumab and favor that.
Do you have any problems getting ustekinumab approved as first-line treatment by your insurance companies?
Yes.
No.
New York versus LA?
Potentially. I mean, 76% of payers have ustekinumab as equal footing as adalimumab. 76%. That's on the sub-Q side. I can't comment on the IV side for a minute because that may be institution dependent. And for those 24% who their payer denies it, they can get free drug. So not just patients who don't have insurance, but if their private payer denies it, they can get free drug. This is a really important point. So perhaps there's some difference.
We've had it. We've had success, but it's not across the board. It's not across the board, but we have had success.
So I think the important point is that many insurers right now, many payers right now, do have ustekinumab after an anti-TNF. And Marla, you already said, just to reiterate, you're not using a concomitant immunomodulator with ustekinumab, just to state the point that the immunogenicity also seems like vedolizumab to be quite low.
It was 2%.
All right, so he didn't see either one of you, and he was placed on azathioprine and methotrexate. And he was
adalimumab.
Adalimumab and methotrexate.
He might have been on that with me or with Marla. I mean, I just want to emphasize, it's not like a wrong decision here. I think,
all right, we'll get to that. Just a second. Give me a minute. So he's placed on 12.5 milligram oral weekly methotrexate and adalimumab. And 6 months later, he continues to feel well. He only has minimal symptoms to begin with, so you can't really follow his symptoms. Yeah. And he asks you, which many patients do after a period of time on any of these medicines, can I stop my treatment? His hemoglobin improves, but it's not normal. It's 11.4, and again, this is in a man, not a young woman. And his adalimumab levels are checked, and they're 14 micrograms per ml, and there are no antibodies. So I guess, Marla, you first. First of all, what do you think about his adalimumab levels, and what are you targeting, and then what would you do next?
Yeah, so an adalimumab level of 14 is actually very nice. I mean, the literature...
What do you shoot for?
Well, if you look for the mucosal, I go for what the literature states on mucosal healing, less so clinical symptom resolution, and it looks like an adalimumab level somewhere between 6 and 10, based on whatever literature you read, appears to be tied to mucosal healing. So in this patient, you would expect, in essence, that you've optimized the dose. There is no data, however, to say if this guy is on every other week. To be honest, I don't think we know the ceiling. We know the floor, but it could be that someone needs 22. And so probably before you would just throw out adalimumab in this scenario, most likely, regardless of level, you would want to optimize it before you moved on to another therapy.
Gil, what do you think? The levels and what would you do next?
Yeah, I agree I don't think that, I mean, based on levels, he's on appropriate dosing of adalimumab, maybe methotrexate's helping with that. But to get to his question, he asks if he can stop the meds. You know, the answer is, well, maybe we could stop adalimumab, but only at the expense of putting you on something else. I mean,
Yeah,
he's
that's
not out of the woods, and I would, you know, the point about symptomatic response really shouldn't, in my mind, have bearing on the decision to discontinue therapy. But the question is, you know, what would you do next? How would I monitor him? You know, I wonder, it's 6 months now. That's probably long enough to start seeing endoscopic response. So I would, you know, if I did a capsule at baseline, now might be a nice time to do a capsule again and compare and see what things look like.
Ah, you shifted your answer. No capsule, now you're doing a capsule.
For
Okay.
fall monitoring.
We'll come back. All right, so Marla, the dose of methotrexate, oral, 12.5. There are a couple questions about methotrexate that have been popping up. What do you think about that?
Yeah, so if you go back to 2006 when the hepatosplenic T-cell lymphomas came out, we were looking to the rheumatoid arthritis data to help guide us on whether we can use methotrexate with adalimumab. And the data going back to 1999 suggested a dose of 7.5 milligrams PO weekly. Both in pediatrics and adult, we looked at that dose. It was as if you were giving nothing. So there was clearly a problem that we were underdosing our methotrexate. Then subsequent data, both by University of Chicago and as well as some work we did with UCB, where they actually looked at the data of patients in their trials, because we had levels and antibodies at every injection, which is the most PK data we've ever had for any anti-TNF program, and they looked at the dose of methotrexate. And they actually showed that at a dose of 12.5 or above, that's when you started to see a drop in the presence of anti-infliximab antibodies. We saw that in IBD, and we saw that actually in the rheum data, because we explored the rheumatology data. So that would be right. I think 12.5 to 15 would be the appropriate dose, and above that, the bioavailability, it drops, to be honest. So I think your max dose you need is 15.
So it seems like 12.5
Yeah.
is okay, orally.
And
you're
your
happy
levels
with
are
everything,
good. You have
but
no
right.
antibodies, you know.
All right, so Gil, he does get a colonoscopy at 6 months, and you pop in his TI, and it actually looks pretty good. But to your point, can he stop meds? I think you've already said no. Continue, probably yes, but now, Gil, you've already answered this, and maybe I'll keep going.
Yeah.
You know, you see that TI, and it looks actually really good, but he's still anemic, he's not quite right, and he's asking and pushing you to stop his medications. So you repeat a video capsule.
Well, and the reason is because we knew, I mean, the burden of inflammation was much worse in the jejunum than it was in the TI. So I would agree here. And that was seen on the CT also.
So it's interesting, and there were several questions about upper GI tract Crohn's that even before this case came through. And phenotypically, or by disease behavior, we know upper GI tract Crohn's is a more aggressive disease phenotype. So I think Gil's point is, you know, don't rest if you're seeing better disease, if he's still anemic and he's still looking good. So the capsule shows you that. So, all right, Marla, now what? So his levels of adalimumab are good. He's healing his TI, but he still has disease on a capsule in his jejunum. And do you continue what he's on now and hope that it gets better? Do you stop all meds and see how he does? Because that's really what he wants to do. He's feeling pretty well. Or do you switch? And if you switch, I list all the options that are currently available. Infliximab, certolizumab, azathioprine, ustekinumab, Vedo. Or do you combine biologics? And is anybody doing that yet? Or is there something else you would do at this point?
So, you know, again, we all have these cases where there's some parts of the bowel that gets better, or that are more responsive, and you say, well, do I throw out this drug, or do I try and attempt to optimize? And in a case like this, his anemia actually, or his hemoglobin, could be something you can follow, by the way, because that looked to be tied to the fact that he had persistent, and still anemia. So to be honest, my gut feeling would be is that that looked still pretty nasty to me. And I'm either going to give him infliximab. If I'm going to stay, actually, I would be more assertive and aggressive with this class if I'm going to go.
So you give him infliximab even though you're happy with the adalimumab
Yeah,
levels.
but I'm not always so happy about adalimumab.
Okay.
Okay?
So
So that's
you're
a different
considering
question that you're
infliximab.
asking me than the level. Do you know what I mean? Like,
Or what else would you use? Or is that what you would
yeah, I
give
think
Imedex?
I would, in this guy who had some response to TNF, and I just think I need to have better flexibility on my dosing, and I want to give him the best chance to see before I throw the class out.
Would you give him 10 mg per kg from the start, and when would you check levels?
I wouldn't give him 10 per se. There's not an alarming scenario about him that says he's going to stool it out, so I'm less concerned about that. By the way, what's his albumin?
His albumin is, actually, it's a 3.2.
Yeah, so because he does have jejunal disease, so that's something we would also want to monitor. And I would actually check levels at week 6. And there's a lot of increasing evidence about checking levels very early with infliximab, because if the patient can't make it to week 6 with a level of 17, if it's below 17, they would need it every 4 weeks.
So you would escalate based on an
Yeah.
early check.
Yeah. So, because I'm still not convinced that ustekinumab, following someone who isn't a fabulous responder to ADA, is really going to be a success story. So it gets back to what we talked about, the sequence. And that's kind of my gut feeling about this case.
And then Gil, there are a couple questions that, the guy symptomatically is feeling pretty well. His jejunum's bad. His ileum looks a lot better. What about veto? And would you use veto in this case? And what about combination biologics? Have either of you done that?
So, I think related to what Marla showed data about veto, and maybe it's just clinical experience with sort of bad small bowel disease. My sense has been that veto just doesn't seem to give as robust a response as experience with as I might expect with anti-TNFs. I think based on
In Crohn's.
in Crohn's,
Yeah,
yes,
small
small
bowel.
bowel disease.
Yeah.
So veto probably wouldn't be the drug I would go to if I'm going to switch, and I probably would switch given the adalimumab levels to a different. I would want to switch to a different class now that ustekinumab is available and he hadn't been on it. I would switch him over rather than give him infliximab. But one thing I also would do, and I know you're not going here with this, but this kind of makes me a little bit worried. The capsule looked kind of bad. He did have healing, pretty good healing in the ileum. I would want to do a deep enteroscopy to get biopsies of that jejunum just to make sure we're not missing anything else,
Like malignancy?
like lymphoma.
Uh-huh.
Or you could argue potentially even adenocarcinoma
Right.
because some of these small bowel disease.
Yeah, exactly. And I mean, there's something that's just not
age,
quite
yeah.
adding up. There's the ileum that is healed, but the rest hasn't, or maybe even looks worse.
So one point that Gil's bringing up, even though he didn't turn out to have a malignancy, some of these patients too in the mid-small bowel will start to stenose, just distal to what we're seeing. Now the capsule did go through, so it didn't show that. But interestingly, this is where I might be old-fashioned. I still might think there's a role for even a small bowel follow-through, because if you start to see luminal diameter changes, this may be a guy that needs a mid-small bowel resection at some point. But your point's well taken about malignancy.
And then you asked about, I was going to comment about combo therapy. But.
Oh yeah, so I just want to comment on the vedolizumab in the small bowel proximal. When Gil and I had shared some patients, and we had patients on natalizumab, and then when veto came out, and these were patients who obviously were desperate and we needed them, they had extensive small bowel, deep ulcerations, had complete mucosal healing with natalizumab, confirmed by double balloon. When we switched them to vedolizumab because we thought that was the natural thing to do, recurrence of their small bowel disease. So I think both of us feel pretty strongly about that, especially the proximal small bowel effect of vedolizumab. And yes, I've used adalimumab plus vedolizumab in
In combination.
combination.
And how long do you overlap?
just for induction.
So you induce with which? Just to be clear.
Patient
I
is
know the
on
answer.
adalimumab,
Yeah.
often, let's say, and then I'm adding vedolizumab, get them to maintenance, and then they come off their adalimumab.
So one thing for the audience that you're going to hear a lot, potentially next DDW, if not the following, there are combination biologics. So now when we discuss combination therapy, it's likely not going to be talking about thiopurines and methotrexate. It's going to be talking about two different mechanism of action biologics, and whether they're sequential, whether their combination, as Marla's saying, and backing down to one for maintenance. Stay tuned. If you think it's complicated now, it's going to change.
I think
So this is the last slide, and then for those in the back, we're going to do the quick ARS, but then we have a lot of good questions that I want to get to as well. But go ahead, Gil.
Yeah, no, I was going to say my one experience with combination biologics is in a patient who we were treating two different diseases. We were treating his AS with adalimumab, and we were treating his Crohn's disease with vedolizumab. And when we tried one or the other flared.
Right.
And he needed to be on both. So, when we think about combination therapy for two different diseases, I think that's one rationale. Thinking about combination biologics just for inflammatory Crohn's disease, I think that's a different question.
I agree.
And I think just
And we don't know yet. I mean,
we
to
don't
be
know.
honest, we're not standing up here, sitting up here and saying use combination treatments. As Marla starts talking, if you guys could bring up the ARS, we'll start those as well.
So I would like to say that there's some evidence in patients who are overlapping anti-TNF with ustekinumab, there's increasing risks of infections like pneumonias. And
Right.
I've had, unfortunately, one who got extremely sick because there was still a lot of TNF in, and then I added ustekinumab because I thought you didn't need a washout, but there's increasing evidence that you probably do. That merits further exploration.
So
Yeah.
the message from all of us is that's off label now, don't do it, and it's something we need to wait for the data.